Welcome everybody to this little presentation again. Okay, so this is our second high tea that we're having, and we've got a few people joining us today, and very cool and welcome. So what I'm going to do today is just present a case history, but I would really like interaction. So if you are sitting there on mute and you want to talk, just unmute yourself and have a chat and ask questions. So this is the history of this young girl. She was a 16-year-old girl that came, just a new patient, first presentation to our clinic. She was booked in for a routine exam, and so we did that. Generally, oral hygiene was really good. She wasn't a flosser, but she had an extremely high level of anxiety, about all dental care. And when I found what I found, she was definitely not going to have an injection, which put me in a bit of a pickle, because you don't, it's when they're 16, it's very, very hard on that first visit, when you've seen what I've seen, to be able to talk them around. But she did not have any pain. So when we took the x-rays, well, before I took the x-rays, this is what I noticed. So when you notice a lesion like this or a shadow like this, you're pretty well aware that there's something brewing underneath. And like, you don't say anything, of course, until you've seen the x-rays, just in case it might be a hypermineralized spot, but it wasn't. The only lesion that she had in her mouth was this 1/6 here. Now, because of her anxiety and her adamancy that she was not going to be having LA, and the fact that there was no symptoms at all, I suggested that we try to use some silver fluoride to not only take care of the bacterial activity that I knew was going on down in here, but also to help with the sensitivity, with the aim that we may be able to complete the procedure if she kept that level of anxiety up without using LA. It was a shot in the dark, but it was worth taking, because in my experience, if you are really nice to the patients the first couple of times and you don't try and force what you think is what they need on them, then they're more likely to come around and know that you're a reasonable person. And that is that's what we did in this particular case. So what I did, and this was taken in I think it was January, this x-ray, and then all I did on this tooth that day, apart from discussing everything with her parents about flossing and everything, is I used a high-speed burr and I just went through the marginal ridge from the top. I did not break the side at all. I just went through. It kind of crumbled away a little bit anyway, but I just needed access to that. Now, the idea that she was going to come back and see me in about 3 or 4 weeks to see where we were at with this tooth. However, we had the Townsville floods, and she disappeared until May. I had made her a little end tuft kind of toothbrush to manage that. She was flossing, and what I routinely do when I'm using silver fluoride, and I've done this kind of thing, is I get a toothbrush, get a scalpel, and I take almost all of the bristles off, and I make them just a couple of bristle bunch end tuft brushes, so that they can actually get in there and keep some of the food out. And that seems to work really well. But in this case, I didn't see her for another 4 months, and 5 months really. So when she came back, this is what we saw. Why is this not working now? There we go. All right. So and I used the CSDS on this patient. So you can see that I just went through the marginal ridge just there. We took obviously a little tiny bit of the side off. But when CSDS is a caries status disclosing solution, Well, this is what it did quite beautifully. It exposed the extent of the caries all the way around here. So that darkening is where the caries had remained, had stained up, and that's, you know, that's where it had exposed that. Now, when she came back in May, she had not had any sensitivity, no pain with this tooth whatsoever. She was keeping this really nice and clean. And there was a little bit of debris in there, but there was no activity, plaque activity. So it was kind of cool to see this, this photograph here. So what I did with her is I discussed the fact that I didn't know how we were going to go with local anaesthetic, without local anaesthetic, but I said I would work with her and we would, you know, slowly work away at this tooth, and she was going to tell me how it was going to feel for her. So what I did is I obviously did a little bit of high-speed work around here, and I did some low-speed cleaning out of the black callus. And this area here was the remineralized dentine, and it was hard. It was hard to feel. It was not leathery at all. And I managed to clean right up around here without increasing the size of the cavity to chase the fact that I had created the remineralized dentine. I didn't have to work my way around to get to it. And I did a little bit more cleaning there just to make sure the margins were really well cleaned. And this was all done without local anaesthetic. She was not having any discomfort at all. And then the next step that I did there is I put a GIC. I used an Equiafort liner, and I covered the whole of the dentine with that. Now it looks here that I've actually ramped that right up to the occlusal, but believe me, there was a margin of enamel right around there. And so we've just taken photographs as we went through, and then I filled that then with composite over the top, and then I sealed the rest of the tooth. You know, when you blow up your own restorations this big and you see this kind of thing, you sort of think, I could have done a bit better there. But it was, what I filled that with is the composite, the GIC base. And then I used the composite, but I put flowable down around in the proximal box, and you'll see the evidence of that on the X-ray. And then we did the composite resin over the top. So this is the X-ray that I had after the restoration had been done. So you can see how, I'm going to show you a comparison in a tick, but this area here is the flowable composite, and then we've got the build-up. There is some GIC here. This area here is the remineralized and arrested, well, it's the arrested caries taken off, because the caries is the infected part of the tooth, and then what we were left there was remineralized dentine. Now, I'm going to be following up this patient with X-rays as we go through. She's due again in May. Dr. Graham Craig, says what we'll see is a progressive lightening of this area. And so that's going to be really interesting. But when you look at the two X-rays, now this was in January that this one was taken, and this is in May, and you can really see a definitive line where the caries has stopped and the tooth has rested and the remineralization has begun. And for me, that was a real success story, because there's one thing that I did do is I managed to keep the part of the tooth that we were dealing with contained and quite small. So it was, it certainly conserved tooth tissue. And, you know, as far as her longevity of that tooth goes, you know, fillings will need to be replaced as she goes through life. And if she flosses, which she's doing now, we're going to get a better outcome for this particular restoration. But I'm hoping that I've saved her one of those steps if that filling needs replacing along the way, then it, you know, every time you fill a tooth, it gets bigger and bigger. Hopefully she's saved that, but we've also kept the caries and the demineralization right away from the pulp of the tooth. What I like to do is remind people of this photograph. Anyone who's done any of my courses would remember this photograph, and this is where the initial, that black stuff that you saw when she came back, this was the dead decay, the black callus, or the burnt toast, as I tell the kids it is. This here is what we've got here, and that is the remineralized dentine. So it's an interesting case, and I'm, you know, I'm open to discuss that. I'm going to take the sharing off now and unmute and have a chat.
Kathy, what happens if they go off to a private dentist and someone who doesn't know about silver fluoride and they see this? They're going to want to go in and get rid of all that darker area because they won't realise it's remineralised too.
Well, I've overcome that by you educate the patients really, really well. But I've also made some post-treatment cards. Here they are here. I'll just show you. And the post-treatment cards and the template for that is on the ARMA website. Okay, so this basically says, "Dear dental practitioner, so-and-so has previously been treated with the application of silver fluoride for active caries management or sensitivity. Should you notice any blackening or dark areas under, around the existing fillings or between teeth or in open lesions, please consider this as a part of your dental evaluation. The use of x-rays may be prudent for accurate evaluation." And then we've got the ARMA, you know, description there. So every patient that I use silver fluoride on gets one of these, and I show the parents the before and after x-rays, and I say, if anybody wants to take out this filling because of what they've seen on an x-ray, then I want you to get them to request the x-rays from our practice, and we will send that to them, because I do not want people, I tell them that, I said, people are going to see this and recognize this as recurrent caries, and it's not. And I guess what somebody said, the first thing they'll do is when they actually do take out the filling and they get down there, if that ever happens, and hope it doesn't, they'll go, oh my gosh, yes, this is what it is. But I like to do this. So these little cards, I think, are a key to having a successful outcome long term for those patients. So,
thanks, Kathy.
Yeah,
I think that's a great way of managing it, Kathy. What was the name of that website? Sorry.
Oh, the ARMA, A-R-M. So it's www.armer. And that's, you register for that, and all of the resources, if you haven't seen them, the chairside assistance, where you can guide people through that, is all there, and also the parent information brochures, so they can go home fully understanding the process that you're taking them from or through. And on the website, there's two templates. There's one of them where you can just print out a whole card, like if you use thick cardboard, you know, to print it out, you can chop up these ARMA cards by themselves. Or the other thing, there's another two templates. I get these, and in our practice, we just get them. They're not owned by me. They've got, you know, they've got nothing to say where they belong to. What they do is you can use that and send that off to Vistaprint, and I think it's like $17 and you get 250 of them. So it's worth investing in that if you need to. Okay, is it okay to use petroleum jelly as a holding agent instead of Durafat? Yes, it is. You can do that if you like. And the reason why, the reason why I use Durafat is because you get more fluoride into those lesions, and you don't go over the fluoride application. like a lot of people go, oh, you're using silver fluoride and then you're using stannous fluoride and then you're putting durafat, and that's really a lot of fluoride, but it's very site specific and it's very minute amounts, and it falls well under the application dose if you were going to do a full mouth durafat application. So yeah, but you could use that. Whatever you put on there has to be held there for a while, because the greater the silver uptake and the fluoride uptake, the greater the benefit for this tooth. I would definitely not have used the Riva Star product on this particular tooth because of the depth of the lesion and the fact that it's got a very high pH of 13, and the osmotic effect of the pulpal tissue of the liquid moisture coming out through the tubules would be quite painful, and you want to try and avoid that. And of course, the Riva Star product was designed for very deep lesions, for a quick cleanup and a cleansing, but they were always anesthetized in the correct format of where that product was designed for. So it's a good product to clean up a lesion that you've already cleaned all the bacteria out of, and you just want to make sure that you're not leaving anything down there. That's what it was designed for, a quick on and off. And so if you're going to have that close to the pulp with that product, you would need to make sure you had an anaesthetic in place. More questions?
No, just a statement.
Yeah.
I was really, really pleased to see the IAPD webinars with Rum and Betty talking about using silver fluoride in this current COVID-19 times a lot more widely. They were really good. If you haven't seen them, recommend for people to go and watch.
Mm-hmm. The AAPD or the IAPD?
IAPD, international.
Yeah, I haven't seen those ones. I've seen some of the ones that have come out from America. Yeah.
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 And the Global Dental Fund, I think,
right,
were ones that had sent them out as well.
Yeah. Yeah, no, it's good. The beautiful thing is about this COVID era, and we are still in it, even with level 2, people are going, well, we can't use, you know, aerosols and things like that. You can definitely do a silver fluoride application and get great results without drying the tooth with air. If you dry it well with a cotton pellet first, and then go and do the rest. That you're going to, you know, I've done that before, because sometimes you just can't get, particularly like on hypermineralized teeth, you can't get any air near those teeth. But to dry it with a cotton pellet and then put an application on, it gives amazing relief to those children, so that next time when you come back, you can use air and you can really get that tooth remineralized, desensitized, and then you work out what you're going to do with managing it. But at least they're able to eat on it and clean it, and it buys them time, and you can fill it. I can fill them without LA. It's just brilliant. Yeah, so that's a whole different thing, but yeah. Yes, it's getting there, and I think it's, you know, silver fluoride is born for a time like this, where we need to have an alternate look at what we can do with our patients. Okay, any other questions or comments?
Just wondering, how do you follow up that X-ray or biopsy, or what often do you do?
Yeah, I follow those up. I take X-rays every 12 months, and they come in regularly for 6 monthly reviews and checkups. You know, that's what we aim for. So that patient, yeah, that patient, I will take X-rays. Look, after a couple of years, I won't need to take X-rays, but my sticky beak brain will probably always want to take X-rays on her.
Yeah, that's fair.
Yeah, because I mean, you know, like a lot of this work is so different. But if I have a clinical record of, you know, the X-rays and the photographs, that's where we're going to get, I guess you would call it a retrospective study in the making. So yeah, her x-rays in 12 months time will be vitally important for the continuation and the lack of symptoms and things like that. But I believe that we have achieved a good result for her, and you know, and most of the patients that you see that you begin treatment with this way, after a little while will accept whatever you're doing for them. That they will, you know, they will trust you enough to allow you to do an LA if you needed to. In her, I didn't need to. That was just one-off application over the 6-month period or 5-month period, and I didn't need to use an LA. But you know, I've got other cases where I've been able to use an LA because then I can get a, you know, a good band on and things like that. What I did with that patient though is I put topical anesthetic around the gingiva before I put the matrix band on. So she was happy with that. Yeah. Is anybody using, Christine, you're using silver fluoride still? Have you done anything?
I'm using the CSDS now.
Right. Have you done anything on the permanent teeth?
That's what we're starting to do. We're looking at doing very early lesions with the silver fluoride so that we don't go in with burrs.
Right. Yeah. Yeah.
And we're going to keep records of them, a bit like a study, just to appease management.
Yeah. Yeah. It's one of those things that the more you use silver fluoride, the more confident you get, and the more you'll be going, okay, I can start using that in this thing. You know, I started out with small deciduous teeth, and then I started, you know, saying, okay, I'm wondering if we could use it here, and then we went to I went to hypermineralized teeth because I understood the properties and I knew how it was going to work, and then, you know, we get these kind of cases, which I think in the future is going to be very advantageous. So
when I first tried to get it used probably 10-15 years ago now, I kept getting told by pediatric specialists that it was a third world answer to a problem, and I kept telling them where I work it is a third world problem. So
yeah,
I'm just so happy that I can use it.
Yeah, yeah. The old thing about it being a third world is because they had everything else available to them, like GA and you know, and modern materials and things like that. But we don't have that at the moment. And it, you know, I'm sort of presenting some of these cases because it's not third world. This is a private practice that I'm doing it in. This is where the patients come to me for this kind of treatment. And just going to have a look at another question. Does that mean that CSDS? Okay, righty ho, yeah. So yes, the cost of CSDS. Now, CSDS is not a silver diamine fluoride. It is a silver fluoride because it's water-based, and so therefore the diamine part of this SDF is the ammonia in it. And Revastar is very high ammonia because it was designed for a purpose that was quite different to what I'm using it on that case. So the Americans have got a silver diamine fluoride, which is a different formulation from Revastar, and their pH is only 10. It's only got 8% ammonia in it. The amount of ammonia that's in Revastar is between 15 to 20%. And what we've got here, of course, in the water-based and the CSDS, there is no ammonia and it's all water, so it's it has been 6.3 the pH. It's just now gone down to 6, between 5.5 and 6 in the latest batches that are coming out. And so yes, it's way cheaper. So the Revastar traditionally comes in those little capsules, and one of the things when they were making the rebirth of the silver fluoride, because this is the same stuff we used to use in the 80s, it is they did a survey of all the people that or are already using silver fluoride, because people have been using the water-based silver fluoride over the last 40 years, being made and given to them by Dr. Craig in very, very small amounts, but it wasn't commercially available. Anyway, when everybody he sort of said, how do you want this? You know, and they all said, no, we don't want the capsules. We want the bottles. So even though the CSDS was passed by the TGA back in 2014, it was only available commercially in 2017 because they were waiting on the bottle. The little dropper bit had to pass the TGA because it gives out a measured dose. So what you don't want, and what they didn't want, is anyone to use a material that was likely to stain, and you push the bottle in it, you got a squirt, because you wanted it as a measured dose. So that's why they can, the cost is around about 50 cents a drop to use the CSDS product. If you're using Riva Star and you're using those little capsules, that the average is about $10 a patient. So there's a really big difference there. I know Riva Star are making some of it there's a small bottle that you can get it in now as well. I don't know what the cost of that is. One of the reasons that they originally put it in the capsules is because of the high ammonia and the potential for gingival burn or soft tissue burn. So they wanted to control the amount that was actually dispensed from those containers. So that's why they only had 0.5 of a mil in each of those containers. So yeah, it is cheaper. So, and Christine, I think that's why you're moving over to that, isn't it?
Yeah, because it's cheaper.
Yeah.
But I like it better because I can see it's working. You can see that black immediately. You can see where you've put it. It's fabulous. I'm really enjoying using it.
Yeah. It's not just cheaper, but it's actually more effective. Because, and you've got to remember, I don't work for any of those companies. I'm just passionate about getting correct information out to people. It has a higher amount of silver in it and a slightly higher amount of fluoride than either of the other products, because they can pack more in per weight per volume than the others can, because they don't have to put the ammonia in there. So it's if you're looking at silver, I don't know whether anyone's looked at that video that I put up on the Exchange page the other day, the link to that on the on how silver works on bacteria. So if you're looking at silver taking out the bacteria and stopping the activity, the more silver that you can put in that lesion, the better off you're going to be. And so therefore, when you have something with a higher silver content and a higher fluoride content, you're going to get the best of both worlds, because you can leave it on there for a really long time. What I do when I put the Durafat or whatever you're going to use over there to hold it there, I also tell the kids not to brush that tooth that night, because that it forms a plug, and like I want maximum uptake in that. So I just sort of say, oh, I've already cleaned your teeth today, so you don't have to worry about that one. I think I'm really nice.
I find that they don't complain about the smell as much either.
Well, there is no smell. Yeah,
that's right. Well, the Riva Star smells.
Oh, it does. Yeah. And you know that.
And the kids don't.
Go on.
Oh, sorry, and the kids just don't like the smell. So I find there's more acceptance with the CSDS.
Yeah. I just call it my magic water, because it looks like water, it smells like water, it doesn't taste like water, but you can certainly manage that by changing up the flavor on their tongue as soon as you've finished it. I put some stuff on there that tastes yummy, and then that's okay. But I think the thing with the whole smell thing, that kids are very receptive to things that they don't like, and so when people have got a high, if you are going to use Riva Star, and when I did use Riva Star before I got my hands on the CSDS again, I used to just tell them, look, I'm going to put some stuff that you know, smells really weird on your tooth. Okay, so I prepared their brain for it, but it was much better if we didn't have to do that. Yeah, so and it's really good with little kids because you can show them what it's going to look like on their finger. Pop that on like a little drop of water, and you can paint that on with a microbrush, and you can say this is what it's going to be like, and then you can just do a switcheroo with your Dappins dish and then put on the silver fluoride, and they have no idea. They think you're just getting magic water. So yeah, but yeah, so you know the difference in those, you know, the efficiency of those two products for what I'm talking about today is the fact that it's got more silver and more fluoride in it, and you can leave it there for a long time. Okay, how are we going for time? Oh, I think we're going to get kicked off soon. Okay, we've done about half an hour. Has anyone else got any questions today?
Yeah, we attended one of your seminars last year as a group with me and some fellow clinicians from our clinic.
Right.
I just did have a few extra questions, if that's all right, if I can ask you before we get kicked off.
Yeah,
I was just frantically hunting for them. The main thing I wanted to ask was about if we can use petroleum jelly, which is good.
Right, okay.
Just asking if we can place composite directly onto the surface. I assume not.
Yes, no, you can. You can. After you've done a clean, what I would do there, I would do a cleaner, you know, like when you get them back, okay,
yeah.
You can do that cleanup and get your cry-dentinaire, so you can get really clean dentine, an arrested dentine, and then you can treat that like normal. So yes, you can etch on top of that and do your normal composite. I like personally to have a GIC as a base on a permanent tooth, only because you know you've got all that extra fluoride going down there. And also too, I've always been in the habit of doing a GIC liner because you've got two different materials, and as far as thermoconduction goes, it's almost like when we used to do a lining under our amalgams. You always put a lining under there so that you didn't have the thermal conduction, and oftentimes composites, they can actually become quite sensitive, even if they're not leaking, and particularly if they're deep. So that's why I chose to do that. Yeah. Also too, the Equia Fort that I use is quite opaque, and so if there's any of that darkening of the dentine that's arrested, it will kill, as you saw, it kills the colour translucency coming through.
Yeah, I saw you were the photographs that it looked completely aesthetic as you removed all the burnt toast or the black callus. But you don't always get the result, is it?
Sorry?
You don't always get that beautiful result of getting all the black removed? In
a permanent tooth, yeah, I always go for aesthetics in a permanent tooth. Yeah. So I just clean around the edges, and I do go for that. Not if the tooth is hypermineralized though. Okay, if the tooth is hypermineralized, I leave as much as much remineralized and solid dentine, not dentine, but enamel as I can. But most cases, and that's a completely different set of rules there. But I'm also not putting a composite on those. I put a GIC on those, and I have a very good rate of those teeth not going on to break down. They don't need to break down. Yeah.
Okay, all right. And conditioner wouldn't modify the smear later. Do we need conditioner before placing GIC, or you just remove the burnt toast?
No, I use definitely a conditioner, because you have to, once you've cleaned the black callus off, it's like you've got you're now back to your regular treatment, okay, protocols. And so, yeah, you definitely need to get the cavity conditioner in there. And actually, there's studies in the States that have been done where if you use cavity conditioner after you have used silver fluoride, not in the same visit, of course, but if you know, like I was explaining, if you get the kids back and then you use cavity conditioner and then your GIC, particularly if it's a high viscosity GIC, those GICs have got a better and a stronger, a greater, what they call shear strength, than if you have not used conditioner. So it is in the restoration's best interest to use the cavity conditioner, and it's for what you're doing. It's for removing the smear layer. So
Okay.
yeah.
Understood. Thank you.
Yeah, no, that's all right. Yeah. So is anyone interested in doing more of these? If they don't all have to be about me, if anyone's got any case histories, just let me know, because I think it's really valuable to look at the case histories in this kind of, you know, almost, what would you call it, you know, small group session. And I've got some dentists that I know that I work with that use it in their permanent teeth. They use silver fluoride as part of their basically their crown preps to help with desensitizing everything before they go ahead and put the crown on, particularly if they're doing it on hypermineralized teeth. Righty, well, if that's all, I'll sign off. Okay, I'll go and have a proper cup of tea, and I will see you on the Facebook. Okay, bye.
Thanks again.
See you later. Bye.